Good morning for everyone on the West Coast and afternoon for those of you on the East. We're very excited today to present the oral chemotherapy for colorectal cancer. We will begin our webinar in just a quick bit. Just a quick reminder today that we will be able to answer questions, or excuse me, to facilitate question asking at the end of the webinar. Please go ahead and make sure that you locate the place on the computer where you can type in questions. It's a sidebar for comment. We welcome any and all questions. Thank you all for your participation, and we will begin here in one quick second. Okay, great. With that, I'd like to welcome our speaker, Dr. Anna Verghese, who is actually a very versed as a clinical provider in oral chemo and the recommendations around oral chemotherapy. We are excited to have Anna joining us today to present the patient perspective as well as considerations about where we are in the marketplace with oral chemotherapy. So very delighted to have her. Just a reminder that after today's webinar, we will be archiving this series as well as all of the future webinars. And then, of course, on our website, you can review all of the collection of webinars that have been archived there as well. We will be sending information and surveys for you to ask or to fill out to provide information about how you've received the content and the information, thoughts about it, as well as opportunities for future webinar series, as well as a Blue Star pen for thanking you for your time and being a part of our Fight CRC family. And again, we do ask that if you ask any questions, that they are actually at the right side of the screen. You will be muted throughout the duration of the presentation as Dr. Verghese does present. And of course, follow us along with live Twitter chat, hashtag CRC webinar, where our social media team, Danielle Verghese, as well as Michael Sola, will be helping provide some information through the social media waves about today's most salient pieces of information. Next slide. And we do want to just give a huge acknowledgement of our LISA fund and noticing and actually indicating our true commitment to late-stage research in the fight against colorectal cancer. So over the last 8 to 10 years, we've definitely been devoted towards funding specific researchers in their quest for advancing treatment for late-stage disease, and we're very excited that this year that we're able to donate over $100,000, with 100% of these funds being donated directly to our research grants, as well as our aspiring research scientists. So we really would love more of course, support for this program and to learn more about what we're doing in our specific research portfolios for each one of these investigators. Please visit our website. Next slide. And getting involved. Just a quick shout out to all of you. The reminder that there are a number of ways to partner with us. Post it, like us, share us, Facebook, tweeting, share your comments, share your stories. Join in our events. There's a number of ways for people to get involved to really be a part of the Fight Colorectal Cancer 1 Million Strong movement. We need all of you. We need all of the support, and we're very excited really about growing the number of people that we're serving, as well as the number of people who are joining us to help build better programming and resources for people who are fighting or surviving or need to message about the importance of colorectal cancer treatment, screening, as well as quality of life. So just a quick reminder that today that the information that's provided today is utilized for patient education, for making informed decisions, for having the best blanket of information about where to go in terms of information about treatment, as well as all of the information described to really help people really think about their journey. However, this does not replace medical care. Our speakers are not allowed to specifically provide direct medical one-on-one responses to questions or to help guide medical care directly. Definitely making sure that we're giving you good salient information about the state of the science and medicine so that you can have a very good informed discussion with your healthcare provider, family, and team when thinking about the issues. Just of course that if there is ever a time for specific medical care, 911, or directly with the clinical provider. Fight CRC is here as a patient education and resource, but of course not a direct clinical provider. And so with that, I would like to introduce our speaker today, Dr. Anna Verghese, who's an assistant attending physician in the GI Onc services at Memorial Sloan Kettering in New York. She completed her medical school at Case Western in Cleveland, her internal residence at Beth Israel, and then in Boston, Mass, and then in her medical oncology fellowship training in New York at Memorial Sloan Kettering. Her clinical and research interests center on developing new treatments for patients with colorectal cancers and cancers of unknown primary. And so we're very excited that Dr. Verghese is joining us today, who's done a lot of exploration and looking about the implication of oral chemotherapies. I'd also like to just thank Dr. Verghese as well as Kevin McAbee for the time in putting together these presentations so that we can really provide the most pertinent and good information for all of you. So with that, I'd like to turn over the presentation to Dr. Verghese, and again, we will be doing the question and answer session with Kevin at the end of our presentation. Dr. Verghese?
Hello. Thanks so much for the introduction. Let me just... Okay, great. So hopefully everyone can see my slides from here. Thanks for the introduction, Andy. Like she said, my name is Dr. Anna Verghese, and I'm a medical oncologist at Memorial Sloan Kettering, specializing in GI cancers, and specifically colon cancer, rectal cancer, and what we call cancer of unknown primary. So thanks for the opportunity to talk with you today about oral chemotherapy for colorectal cancer. As a brief outline of what we'll talk about this afternoon, first we'll discuss just the most commonly used medications for the treatment of colorectal cancer. Then we'll focus obviously on the standard oral chemotherapy medications. So these are medications that have been FDA approved in the treatment of colorectal cancer. And specifically we'll discuss Capecitabine and Regorafenib. And then we'll end on a brief discussion about experimental or investigational oral chemotherapy medicines that are still ongoing in clinical trials and that haven't been approved, haven't been FDA approved yet for colorectal cancer. And we'll focus again on one drug called TAS-102, which has had some promising phase 2 and phase 3 studies that have recently been reported and published. So first, to begin, just with some of the most commonly used medications or chemotherapy medicines for colorectal cancer. And in this table, I have the generic name of the chemotherapy medicine, the brand name, and then other sort of nicknames or other names that you might hear your care providers using as they talk about chemotherapy, and then also how the medication is administered. So the first medicine is called 5-fluorouracil, and this is one of the oldest and also one of the best medications that we have for colorectal cancer. And it's usually part of the sort of backbone of many of the chemotherapy treatments that we use, from early stage to metastatic colorectal cancer. Often you'll hear people calling it just 5-FU for short, and that's generally administered intravenously. There's a second medicine called oxaliplatin. Sometimes you'll hear people just say oxali for short, another intravenous medication that's often given in combination with 5-FU and other medicines. Third medicine listed here, irinotecan. The brand name for that is called Camptisar. Often people will call it Irino for short. There's also the name that it was given before it was FDA approved, CPT-11, that some people still call it from that name. And also this is a medicine given intravenously and often given in combination with 5-FU or other medicines. The next two drugs in this table, cetuximab and panitumumab, these are medicines that are a type of targeted therapy, which has sort of gotten a lot of news recently in terms of targeted therapy or personalized medicine. These two drugs are sort of sister or cousin drugs to each other and are related to each other. And their brand names are called Erbitux and Vectibix. And these medications are useful and can be a useful part of people's treatment planning for patients with a particular kind of colon and rectal cancer. For patients whose tumors have certain genetic changes, this medicine can be helpful. People with colorectal cancer that is spread to other places, or stage 4 metastatic colorectal cancer, often at the time of their diagnosis are tested for a gene called KRAS. And depending on the testing of this KRAS gene, these two medicines, cetuximab or panitumumab, may be useful. These are often, just because cetuximab and panitumumab are a little hard to say, you might hear people use them by their brand names more often, Erbitux or Vectibix, or shortened into just Cetux or PMAB. These medications are also given intravenously and generally given in combinations with other medications. This other medicine called bevacizumab, or Avastin is the brand name, is another kind of targeted therapy, although used sort of for many patients who are appropriate candidates for it, who have metastatic colon cancer, colorectal cancer, or cancer that's spread from the colon to somewhere else. People sometimes call it Bev for short, or Avastin, its brand name. Also given intravenously, and also always given in combination with other chemotherapy medicines. And then there's another medicine called Capecitabine, or Xeloda is the brand name for that. You may hear providers call it just Cape for short. And this is one of the oral medications that we'll discuss further today. And this is basically an oral form of that first medicine, 5-FU. And then finally, there's a drug on the bottom called Regorafenib, and the brand name for that is Stivarga. This is also an oral medication used for patients with metastatic colorectal cancer. So these medications are often given, as I've mentioned, in combination with each other, and also have acronyms that we use, or sort of abbreviations that we use, rather than saying all the long names all together. So one of the most common combinations of chemotherapy that we use is a combination that we call FOLFOX. And this is an acronym for 5-fluorouracil, that first chemotherapy medicine that we talked about. Leucovorin, which you'll notice is not on that list of chemotherapy medications because it's not actually a chemotherapy. It's actually a vitamin that helps the 5-FU work better, or the 5-fluorouracil work better. So FOLFOX is a combination of 5-fluorouracil, leucovorin, and oxaliplatin. Another combination that you'll often see is what we call FOLFIRI, which is 5-fluorouracil, leucovorin, and irinotecan. And then a couple other combinations with the pills and IV medications are what we call Capeox, or you may have heard it called Zelox. It's a combination of capecitabine and oxaliplatin, or Capeiri, which is capecitabine and irinotecan. So I only mention this, and not that anyone needs to memorize this, but just so you know that for the treatments of colorectal cancer, we often use combinations of chemotherapy medications. Sometimes we use just one chemotherapy medicine also. It really just depends on the situation. So today, again, we're going to focus obviously on the oral chemotherapy medicines, and so we'll focus on those medications in bold, capecitabine and regorafenib. So first, we'll start with capecitabine. And the way I'll go through these descriptions is really just trying to answer some relatively what sound like simple questions about the medication, so that we all have some working understanding of what these medicines are and how we use them and what side effects to expect with them. So with the first medicine, capecitabine, just some basic information about it. The first question is what is it? What kind of medicine is it? And as I mentioned, it's an oral form of that medication 5-fluorouracil, or 5-FU that we say for short. And as I mentioned before, 5-fluorouracil, or 5-FU, is, again, one of the oldest medicines that we have in the treatment of colorectal cancer, but still one of our best and most effective medicines. So this medicine is really an oral version of that medicine. It's given, obviously, orally, as I mentioned. It's also given in tablet form. So there are two different strengths, 150 milligrams and 500 milligrams. And so you might find your doctor may give you combinations of 500 or 150 milligram tablets. Often we'll try to just stick to one to minimize the risk of, getting these tablets mixed up or getting them confused with each other and mistakenly taking more medicine or less medicine than you're supposed to. So often people will take 2 or 3 or even 4 of those 500 milligram tablets, as are some commonly given doses. But the doses really depend on how well you're tolerating the medicine and your weight. So there's not one right dose for everybody. And the next question would be, how often do you take it, or what kind of schedule are you taking this medicine? And this medicine is generally taken twice a day. And it can be given in a couple different ways. I think the most common way in which we use it is in this 3-week schedule, where you take it twice a day for 2 weeks in a row, and then 1 week without any medicine, sort of a rest week, or a time to recover from any side effects or issues you may be having, just a time to be off the medicine for a little while. Sometimes we'll also give it just on a 2-week schedule if the 2 weeks in a row is too much for people with respect to side effects or issues, or for some other reason. Sometimes people will also give it just with 1 week in a row with 1 week break. But again, when you're taking it twice a day. So the next question is just, in what situation do we think about using capecitabine? And this can be used for patients with early stage colon cancer, for patients with stage 2 or stage 3 colon cancer. For patients with stage 2 or stage 3 colon cancer, generally that means they've had a surgery and it's shown that their cancer was limited just to the colon, and that's generally for stage 2 colon cancer. They also, during a surgery for colon cancer, will take out many lymph nodes around the area of where the colon cancer was. And if there are any of those lymph nodes are involved with cancer, we call that stage 3 colon cancer. So after people have colon cancer surgery and if they're found to have stage 3 colon cancer, we almost always recommend some type of chemotherapy afterwards, in case there's any cells that were left over with the surgery, or in case those cells had a chance to escape outside of the colon and the nearby lymph nodes before the surgery had a chance to happen. So we'll often recommend chemotherapy after the surgery. And for some patients with stage 2 colon cancer, we may still even recommend, where the cancer, hasn't spread to lymph nodes, depending on what the cancer looked like under the microscope and what the other pathologists and doctors have told us about it, we may sometimes recommend chemotherapy for some patients with stage 2 colon cancer. Although often we don't, depending on certain features of the cancer. But when we do recommend chemotherapy, sometimes we can recommend a combination of either pills and IV medicines, which would be that combination of capecitabine and oxaliplatin. There's also an all-IV version of chemotherapy that we could recommend also, called that FOLFOX combination with 5-fluorouracil, leucovorin, and oxaliplatin. The treatment of stage 2 or stage 3 rectal cancer in some ways is similar to that of stage 2 or stage 3 colon cancer, but there are some slight differences as well. And so for patients with stage 2 or stage 3 rectal cancer, again, cancer limited to the rectum and maybe to the lymph nodes around the rectum, treatments can include chemotherapy around the time of surgery, either before or after. Treatment often includes radiation therapy, either before or after a surgery. And often the radiation therapy is given with some chemotherapy at the same time, often given with that pill chemotherapy capecitabine that we're talking about now. And then finally, of course, this medication capecitabine is often used in the treatment of patients with stage 4 colorectal cancer. And that means cancer which is spread from beyond, sort of right in the colon or right in the rectum and those lymph nodes around it. So when cancer has spread from there somewhere else distantly. Usually the first question people have when I mention that there's a possibility of an oral chemotherapy as well as the IV chemotherapy is, well, doctor, is the pill as good as the IV medication? Really I think with the underlying assumption that something about the IV medicine makes it better or stronger or something. And I think that's why people often ask. And obviously you want to make sure that people are getting the best treatments for their colorectal cancer. And I think the answer is yes, that we do know that the capecitabine pills are really as good or equivalent to the 5-FU IV medication. And we often will use these interchangeably, whether or not we're thinking about giving someone just one medicine. If it's just 5-FU, capecitabine could be used in place of that. Or if we're thinking about the combination of 5-FU with other medications like oxaliplatin or irinotecan or cetuximab or panitumumab. And this we know because we've done studies comparing, and I say we meaning sort of the research community, not myself specifically, but studies have been done comparing the combination of capecitabine and oxaliplatin and FOLFOX, and they demonstrated in those studies that the combination of capecitabine and oxaliplatin, or Capeox, was really no worse than FOLFOX when given in the sort of first treatments for patients with colorectal cancer. And based on that data and others, we feel comfortable using capecitabine sort of interchangeably with 5-FU. Usually the next question I'll get is, what are the sort of most common side effects, or what kind of side effects might I expect with an oral medication like capecitabine? And it's a good and important question because because the oral chemotherapy like capecitabine is still chemotherapy, and it still comes with risks and side effects. And so many of its side effects are similar to side effects you might have seen with other chemotherapy, such as lowering the blood counts. And I mentioned here the neutrophil count, or someone becoming neutropenic. And neutrophils are a type of white blood cell that are important for fighting off bacterial infections. So this can, if it lowers your neutrophil count, that can put you at risk for infection. It can also lower the platelet count, and the platelets are cells that help your blood clot. So if those numbers are low, if those kinds of cells are low in number, then that could put you at risk for bleeding. The medical word for that is thrombocytopenia, when the platelets are low. Another side effect that can be seen with capecitabine is a rash on the hands and the feet, and we call that hand-foot syndrome. And that's what this picture is here of someone's feet. And this can be a range of different symptoms for everybody, and everybody is different in the way they handle and experience these chemotherapy medicines, whether they're pills or IV. But for some people, it can just be mild sort of tenderness or just sort of sensitivity in the hands and the feet, maybe a little bit red, but generally manageable, not getting in the way of doing their usual activities. But for other people, it can be much more severe than that, like what you see on this person's feet, where you have more sort of swelling and redness, and it's really painful, and it could even develop into blisters. And that can happen with these medications. If that does happen, then we would often make changes to the doses of the medication that you're taking. First, we would probably stop it to let these side effects recover, and then if we were going to restart it, we could consider restarting it at a lower dose. Other common side effects you can see are nausea and vomiting, as with most pills. Diarrhea or constipation is possible, as with many of our IV chemotherapy medicines too. Again, similar to our IV chemotherapy medicines, this medicine can also affect the appetite and sort of make you lose your appetite or lose your taste for food. And I know that is something that we all struggle with as we're helping take care of patients, that can happen still with this chemotherapy medication. And it can also have effects on the heart or cardiac complications. And that is similar to the IV form 5-fluorouracil, which can have effects on the heart too, both on the heart rhythm as well as on the arteries feeding the heart as well. All right. And then the next question would be, are there people who really can't or shouldn't take this medication? And certainly there are. This medication is metabolized or sort of filtered through our kidneys, and the kidneys, as you probably know, filter our blood and excrete sort of waste products into the urine. And so if your kidneys don't work as well, you could imagine that these medications or medicines that are usually filtered through the kidney, if their kidneys aren't working well, those medications could build up in your system and give you side effects and issues. And capecitabine is one of those medicines that is excreted through the kidneys. So for people whose kidney function is poor or not as good as it once was, that might be for those patients, this medicine might not be a good idea. This medicine is metabolized or sort of processed in your body through certain enzymes, and there's a small percentage of people who either make less of that enzyme or don't make it at all. And for those people, this medication, as you can imagine, if it's not being processed, really builds up in your system and results in a lot of side effects. We don't, at least at the place where I work, we don't routinely test for that enzyme because it's pretty rare, and our treatments will really depend on how someone tolerates the medicine. So we don't routinely test for that enzyme. But if you find that after you start this medicine, your side effects are really quite severe and more out of proportion than what you might normally expect, it's possible that your body simply can't metabolize the drug, and this kind of drug may not be a good choice for you. And that enzyme, just in case other people here, if in case you've heard others talk about it, or if you have questions yourself, the initials for that are called DPD. And then another question is, well, how do you know if this is the right kind of medicine for you, or how do you know if the oral version of this chemotherapy is a better choice than the IV option? And I think the first point is an important one, both in decisions about chemotherapy, but also in many of our medical decisions. Your doctor is certainly, their job is to help give you all the information they can and to give you the best advice they can. as we make decisions together about what to do next for your health and your treatment planning. But sometimes decisions really, though, depend on a person's wishes and depend on a person. I mean, for the most part, always they depend on a person's wishes. But the decision about oral versus IV chemotherapy, in large part, depends on the person who's taking the medicine. One question that I think can come into this decision about whether or not to do an oral versus IV form of this 5-FU medicine is how people feel about a Mediport. And so what a Mediport is, and when I think of it, is basically a fancy IV, or it's what we call a venous access device. And it's sort of a semi-permanent device that's implanted under the skin, and some of you may have one yourself or know others who have them. But it's a device placed under the skin to the vessels that are related to the heart, and then chemotherapy can be administered directly into a Mediport. When we give 5-FU, almost always we need to use a Mediport, and so the decision to do the IV version of 5-FU is often a decision that goes hand in hand with needing one of these Mediports. And for some people, the idea of having a Mediport or the practicalities of having a Mediport really is something they don't want. So if you don't want a Mediport, this may be a way to avoid getting a Mediport placed. Another thing to think about is that when you're getting IV 5-fluorouracil or IV version of this chemotherapy, you really have to come to the clinic every 2 weeks, or you have to go to your doctor's office or to the hospital or wherever you get this medicine. You really have to come generally every 2 weeks for the medicine, and that sort of ties you to being in a place in a way that, depending on your work schedule or your life schedule or whatever it may be, may not be a real, or maybe it would be better for you to be able to come less often, or to not be so tied to coming every 2 weeks on that schedule. So that's one other piece to take into consideration. The next two are important ones that I think sometimes we overlook. And the first is just, are you the kind of person who can take pills reliably? And that's not any judgment on anybody that they can't take pills, but some people just know, I always forget my medicines, or I really need to stay on time. Like it's a challenge for me to take my medicines on time. And these medicines are important. Although they're pills, they're still chemotherapy, and they're still important for your treatment. So if you know you're the kind of person who simply sort of just has trouble remembering to take your medicines, this is definitely not a good choice. And on the other end of the spectrum, there are people who are so committed to taking their medicine, it almost takes over their life in a way. And not that this cancer doesn't, take over our lives in many ways, but our goal in all of these treatments is to allow these treatments to allow you to do the other things that you want to be doing, not to have your lives overtaken by a treatment. So for some people, the idea of taking a medicine twice a day means organizing their entire schedule around taking their medicines twice a day, which is good because you take the medicines, but at the same time, it's the anxiety and the stress of trying to schedule yourself around that can be overwhelming for some people. And I think understanding how you approach taking medicines and how you approach scheduling and things like that those are important considerations. And those are considerations that really only you or the person who's taking the medicine can help figure out if that's the right choice for you. So I thought I'd give just a brief example of kind of the situation where we might be considering IV versus all IV medications versus pills and IV. So just one example would be, let's imagine that you've had a surgery for your colon cancer and you were found to have stage 3 colon cancer because there were 2 lymph nodes that were found to have evidence of cancer. And so your doctors read your reports and examined you and said, I recommend 6 months of what we call adjuvant chemotherapy. So chemotherapy given after surgery in an effort to kill any what we call micrometastatic cells, or cells that were left over after the surgery, in an effort to kill those cells before they have a chance to set up anywhere else. And so your doctors recommended 6 months of chemotherapy. And your doctor tells you, well, you could either have the all-IV version with 5-FU, leucovorin, and oxaliplatin, or you can have the combination of pills and IVs, with the pill being capecitabine and the IV version being oxaliplatin. So how do you decide which one? And obviously your doctor will help you decide this too. So as I mentioned, the FOLFOX is a combination of those 3 IV medicines. The Capeox combination is a combination of pills and IV. So FOLFOX all IV medicine requires a Metaport. And the way that chemotherapy is given when we give it in this combination of FOLFOX is you would get all 3 medicines on the first day. And then when you finish the chemotherapy that day, you're actually hooked up or connected to chemotherapy, and then you go home with chemotherapy infusing into that Metaport for 2 days or 48 hours. So just imagining a date, let's say you were starting this chemotherapy on April 1st. You would go to the clinic and you'd get all 3 medicines on April 1st, and then you'd get hooked up to 5-FU on April 1st in the afternoon. And then you'd go home with chemotherapy from April 1st to the 2nd and 2nd to the 3rd. And on April 3rd, you may go back to the clinic and get disconnected. And then from April 3rd through the 14th, you'd spend that time recovering from treatments, working, taking care of your families, whatever it is you're doing. And that would be the first treatment. And then you'd come back on April 15th to do the same thing again. And for this kind of treatment, you would do that treatment with FOLFOX every 2 weeks, which turns out to being about 24 weeks or 6 months of these treatments. And so I think the benefits of this treatment is that one of the benefits some people say is that you do have the Metaport, because you can often have your blood drawn through a Metaport, you can have the treatments administered through there, you're not always getting poked with needles and to have your blood drawn or have to have separate IVs set up. So for some people, having the Metaport is a positive. For some, though, a con is having the Metaport, and sort of needing to have that device implanted is, for some people, sort of a constant source of anxiety, and so for some, and also comes with some risks of infection and bleeding and the risks that come with any kind of a procedure, regardless of how minor it might be. So having to have a Metaport placed, having to keep it in, having to maintain it, for some people is a negative with this combination of FOLFOX. It also requires visits every 2 weeks, and then potentially another visit to have the chemotherapy disconnected. So a decision to do FOLFOX for these 12 treatments over 6 months is a decision that requires a lot of time at the doctor's office. The other possibility would be that pill and IV combination, the capecitabine and oxaliplatin. Again, the capecitabine is oral and the oxaliplatin is intravenous. And these are given once every 3 weeks, with the schedule of those pills being twice a day for 2 weeks in a row, and then 1 week to recover from those symptoms and issues that are going on. Because these treatments are given every 3 weeks, we still do them over 24 weeks or over 6 months. So you actually get 8 treatments rather than 12. So some of the positives for people who are thinking about doing Capeox are that, like I mentioned, it doesn't require the Metaport. It doesn't require that 48-hour infusion where you're connected to the chemotherapy. And overall, it's probably fewer visits to the doctor. You have 8 treatments, not 12. You don't have to come back for those disconnections of the chemotherapy. I would say, though, some of the cons or negatives about this is that, and this may just be anecdotal experience, but I think sometimes the side effects with this combination of pill and IV it just seems to be a little bit more poorly tolerated, or people seem to have more side effects. And I think there are at least one reason is that because you're getting only 8 of those oxaliplatin treatments, not 12, the dose that you get with each treatment is a little bit higher. And we know that the higher the dose of these medications, the more likely you are to have side effects with them. So I think that's one reason that the medication, this combination of capecitabine and oxaliplatin can be tough to handle. And also it puts a little bit more pressure on you to every day, 2 weeks in a row on sort of a funny schedule take these medications. And it also puts pressure on you to make sure that you adhere to that schedule because these medicines are important. And again, the capecitabine and the 5-FU are really the backbone of these chemotherapy medicines and probably more important than the oxaliplatin. So the decision about which of these to choose is really, again, your doctor can help, but these are certainly your doctor should help and can give you advice about what they think might be the best choice for you. But many of these choices really come down to what makes the most sense for you. Another question would just be, well, how do you get this medication? And so I think I sort of titled this slide, how do you think you get it? You'd like to think that, your doctor thinks this is a good choice for you, writes a prescription, and then these medications are usually dispensed through what we call a specialty pharmacy, because you can imagine giving chemotherapy medications, the doses are important. Everything about it is a little bit more It's more important to get everything right. It's always important to get things right when it comes to medicines, but when it comes to chemotherapy medicines, it's especially critical. So often these oral chemotherapy medicines are given through these specialty pharmacies. So you'd like to imagine that your doctor thinks this is a good choice for you, decides on the dose, and then contacts the pharmacy, and then they just mail it to your house. Would be how you'd like to hope it goes. In truth, what usually happens is that the first step is just that your doctor writes the prescription. The second step is that your doctor's office will probably call the insurance company to figure out which specialty pharmacy is covered by your insurance so that we can then mail the prescription to the proper specialty pharmacy. And then often the pharmacy will say, oh, we need to have another form filled out before we can complete this prescription. And then your doctor's office may need to complete what we call a prior authorization form. And then the pharmacy coordinates mailing the drug to your house. So then the pharmacy will probably call you to try to make sure there's a time when you'll be home, et cetera, or when there's a time a package can be delivered. So I think when things go smoothly, this is generally how the process should work. I think in truth what probably usually needs to happen is that at every step, you can imagine in a process with this many steps that at each place there's a place for something to get delayed or a place for something to get missed. And really, although your doctor's office should be able to help you with following up these calls, I think it often falls to patients and their families and their caregivers to help follow up to make sure at every step that everything is, that sort of the process is continuing to move as you would expect it to. So I think in a good case scenario, sort of these things could potentially happen as fast as a week if you're using a mail order pharmacy and things like that. But then certainly delays can happen. It can sometimes take longer than that. If they're in any place here in these steps, there's a delay. Then in terms of how you take it, we talked a little bit about this already. It's a medicine that you take twice a day, usually several pills twice a day. And you usually need to take it within a half an hour of eating a meal. And the pills need to be taken whole. So that's sort of a brief summary of Capecitabine, and I'm certainly happy to talk about other questions or concerns that people have with this medicine if there are questions about it. I think it can be a good option for people, but it really depends on your ability to take medicines pretty regularly and also sort of the risks of those side effects and being and sort of needing to be aware that side effects can happen and that they need to be addressed quickly when they do happen. So that means calling your doctor and making sure that you feel comfortable calling your doctor when you have symptoms that you don't, that are bothering you or that are new or different after starting a new medication. So I'd like to talk next about this medicine called Regorafenib. So the first question in a similar way, just so I'd answer some basic questions, would be first, just what is this medicine? How does it work? And it works actually by blocking several different proteins or enzymes that are thought to be important in the growth of colorectal cancer. Also, it's a pill, obviously, and it's given in 40 milligram strength tablets. And these medications are taken once a day, usually 4 tablets to begin with. And they're on a 4-week schedule where you take the pills once a day for 3 weeks in a row and then 1 week off to recover from any side effects or issues. Another question is, in what situation do we use Regorafenib? And this is very different than the situations where than what we may have discussed earlier about the Capecitabine. Regorafenib has been approved for patients with metastatic or stage 4 colorectal cancer, where their cancer has grown despite taking the other IV chemotherapy and the other IV and oral medicines that have been approved for colorectal cancer. So this is for patients whose cancer has grown despite taking 5-FU, despite taking Capecitabine, oxaliplatin, irinotecan, and if they're the right and if you have the right kind of cancer for it, cetuximab or panitumumab. And another next question that's always a question is, what are the side effects that come with this medicine? And in the studies of when Regorafenib was approved for patients with colorectal cancer, they did note the side effects that came with it, and there were several. Fatigue is possible, and for some people it's fatigue where you just feel tired and you want to take a nap, and then you feel better. But for some people it's fatigue where it's really overwhelming fatigue, and you take a nap and you still feel tired. This medicine can also cause that same kind of rash on the hands and the feet, that same kind of what we call hand-foot syndrome. It can also cause diarrhea, as so many of our oral medicines can. It can also cause a couple other side effects that are a little bit unique to this kind of medicine. It can also cause high blood pressure or hypertension. It can also put you at further risk for bleeding. And it can also, this is a rare side effect, but it can cause serious neurologic abnormalities as well. And neurologic would mean sort of impairment in how in your sensation or in your movement. It can also it also comes with risks of bowel perforation, and your bowel is like your intestines or your guts, and perforation is when you develop a hole there or a tear there, and that's a serious medical emergency. It can also get in the way of wound healing. So if you have an open wound or a surgical incision, taking this medicine can impair with your ability to heal or recover from those kind of wounds. And the next question is, how do you know if it's right for you? And I think, again, this is similar to the decision about capecitabine. This is a decision where your doctor certainly can and should help you decide about whether or not to take this medication. But really, this decision is, in large part, depends on how you're feeling and how you're doing. And so your doctor, certainly their job is to advise you and to give you recommendations. But a lot of this comes down to you and how you're feeling and what your goals are. Also, because this is a pill that requires you to, because this is an oral medication, it requires you to take the pills pretty reliably, and also requires your taking a medication daily and remembering to do that. I think the concerns of this being overwhelming are really less for this kind of medication, because probably if you're taking other medications, whether it's for pain or nausea or something else, you've probably been accustomed to taking medications a little more regularly. And I think also the other situation I would think about would be in deciding if it's right for you, and as this should be when we're thinking about treatments, particularly in the metastatic setting, would be what your goals are. What are your goals in terms of your treatment? What are your goals in terms of how you're spending your time and how you're spending your life and things that you're willing to do in the treatment, in your treatment? Because our goals of treatment for metastatic colorectal cancer are a little bit different than they are for stage 2 or stage 1, stage 2, or stage 3, in that although every person's scenario is different, for patients with metastatic colorectal cancer, that often means that we're dealing with a cancer that we can't cure even with these chemotherapy medicines. And so as I often think about it, the goals of treatment in this scenario are always to help people live longer and to help them live better. And the question really can and should be is, does this medication help you do that? And are the risks, do the benefits outweigh the risks for you? And this medication you would obtain in a similar fashion as you do for the capecitabine, meaning your doctor writes a prescription and has to use a specialty pharmacy to get those medications to you. This medication, as we mentioned, is one that you take once a day and you swallow it whole and you take it with a meal. One question that I hear from many people is just with Regorafenib and capecitabine together is, how do you remember to always take these medications? You've got doctor's appointments, you have other medicines you're taking, how do you remember to do this? And you've got families and work and everything else. And I think there's no quick fix to this, and something that I think all of us struggle with. But the two tips that I would have for people would be, one, just to simply set an alarm on your phone or on whatever kind of device you're using, and so that's, if you always have whatever kind of mobile device with you, just set that on your phone, and so that it always goes off, regardless of if you're in a meeting or if you're somewhere else, just so that's one reminder. And obviously a pill box is a low-tech but often very effective way to remember how to take these medications. One tip I would also suggest would be those, because these medicines are different and should be handled differently, or at least that you should I would keep them in a separate pill box. If you have, if you're taking medications for high blood pressure and for other medical issues, I would probably keep these chemotherapy medicines maybe in a separate one. So you might end up having to have 2 boxes. But that would just be one other tip for trying to, or one other strategy for trying to remember to take these medications and then not only remembering to take them, remembering that you already took them and that you don't take more than you're supposed to. One sort of another set of questions, and these are sort of tips not only for in the setting of oral chemotherapy, but I think are sometimes as appropriate here because you're doing so much of the treatment at home yourself, would be sort of when should you call your doctor? When should you just go to the hospital? And again, this is not specific medical advice because every situation is different. But I would say generally, if you've developed chest pain or chest pressure or suddenly are having shortness of breath in a way that you can't really easily explain with a cold or some other medical issue that's going on, those are reasons I would just go straight to the hospital, or I would even call 911 to have them come get you, because there's very little your doctor's going to be able to do on the phone to manage such a problem, or to manage such a problem safely for you. So developing these symptoms if they're new is certainly reason just to seek immediate medical attention. And I mentioned this in the setting of this talk because, like I mentioned, that 5-FU or 5-fluorouracil medicine and capecitabine, which is the oral form of 5-FU, those can have heart side effects. They're rare, but when they happen, they can be serious. So if you develop these symptoms, those are reasons to go to the hospital right away. As I mentioned with Regorafenib, there can be neurologic side effects. There can also be risks of blood clots and things like that too, as patients with cancer and patients who are getting chemotherapy are at high risk for blood clots. So if you were to develop a new neurologic change, and by a neurologic change I mean suddenly you have difficulty doing or sort of some kind of change in the way in your motor or sensory function, meaning you develop suddenly weakness in your arms or your legs, or you develop difficulty with your vision, or you develop difficulty with your speech. Those are the kinds of things that it's hard for a doctor to really make, to do meaningful things with over the phone, because really probably you need to be seen by somebody. And that would mean going again to your emergency department or calling 911. There are some things, though, that the doctor probably can help for you on the phone, and that would be, if you develop what looks like this hand-foot syndrome on your hands or your feet with this rash, if you're developing that, but you're still able to take care of things, you're still able to, use the computer, make your, take care of yourself, make your food, things like that. Those are probably reasons that are certainly worth calling your doctor about, but probably don't need to be addressed in an emergency department. Another situation would just be if you develop fatigue, and I think that is, I know so many of our treatments and this disease can make people tired. And if you develop fatigue that you can't otherwise clearly explain with something, but if you're still able to do things, still able to get out of bed, still taking care of yourself, taking care of your families, that's again something that you could probably talk to your doctor about on the phone, or call your doctor, talk with someone in their staff about it, and then maybe make an appointment to be seen sooner than maybe you would have otherwise. Also, if you develop darkening of your skin and your eyes or your urine, that would be concerning, or if you're developing yellowing of those areas, those would be reasons to think about that we would be worried that you might be developing jaundice or developing some kind of blockage in your liver. And that can be from cancer, that can be from other things. But if you're feeling okay, that's also fair enough, I think, to call your doctor. If you develop those kinds of symptoms and you're feeling unwell, you develop a fever, you're feeling lightheaded or dizzy, that would be the difference between calling the doctor and actually calling the doctor to be seen in the clinic versus actually going to the hospital. But I think probably the most important thing is that if you're worried about anything, or if you're having a new symptom, you should call your doctor. If you're worried, you should call. I think it's certainly reasonable for you to call your doctor, and then it may be your doctor's job to say, actually, this is completely expected and normal, and we can help you manage it in this way. Or they may say, this is very unusual. I don't know. There are other tests we need to do, and there are other things we need to do to figure it out. But if you are worried, that's reason enough. A couple other sort of just do's and don'ts about oral chemotherapy medications, because these medicines are a little bit different than some of the other pills and medicines that we take. The first question, what if I miss my medicine? I can understand why someone would say, well, why don't I just take a little bit extra and that'll make up for it. But these medicines actually don't work that way, and so what you should do is just skip the dose. Don't take an extra with your next treatment or anything, or with your next dose. Just skip it, and then make note of that and let your doctor know. And again, if you find that you're skipping or missing a dose because you're missing, then maybe those aren't a good choice for you. But don't take extra or double up on the dose. The second question would be, what if I can't swallow the pills? Because as I mentioned, most of these pills need to be swallowed whole, and that can be hard if you're already feeling nauseous from the other treatments you're getting. If you're feeling nauseous because of your disease, the idea of having to take pills can be, and if you're not feeling well, the idea of having to take pills twice a day might be a lot to even sort of imagine having to do that every day. If that is the case, then again, that would be reason to talk to your doctor, and that would also be reason to kind of reevaluate if these pill medicines if these oral chemotherapy medicines are the right choice for you. And I wouldn't crush the pills unless you talk with your doctor or the pharmacist who's helping you prepare these medicines. And again, last of all, and similar to what we just talked about, what if you're having side effects? How do you manage them? Who can help you manage them? Your doctor, or your doctor staff should be able to help you able to help you manage these symptoms. And I wrote doctor here, and I said doctor and doctor staff, but it's really a whole team of people. It's never just one person. It's the doctor and their nurses, and the nurses who help give you your chemotherapy. As I'm sure many of you know, they know more than anybody about how to handle some of these side effects. So if you're having side effects, reach out to people, because these are, for most people, new medicines. Nobody expects you to already know what to do about them. So talk to your doctor, talk to the people who are helping care for you, and really don't ignore your symptoms. If you're worried about something, trust your instincts. You know yourself better than anybody else. Your doctor may know the medicines, your doctor may know about cancer, your doctor may know about a lot of things, but you are really the expert on what's happening with yourself. In terms of other drugs that are on the horizon, or other things that we think that have been promising in studies, there is one drug called TAS-102 that I'd like to highlight here. And again, some basic information about this is that it works in some ways. It is similar to that medication 5-fluorouracil, or 5-FU, and it inhibits DNA synthesis directly. And so we think about cancer as being something that's growing more quickly than the rest of your body. So the fact that it can inhibit DNA synthesis may help to kill the cancer better. It also inhibits an enzyme that's important for the DNA as it's reproducing. This is also an oral medication given in tablet form. And I just highlight these two studies. There was a phase 2 study published in Lancet Oncology, which is a very prominent medical oncology journal, and a phase 2 study, and I'll just briefly describe what clinical trials are, in case for those of you who aren't aware. So there are, as drugs get approved for the treatment of patients in cancer and other diseases, they usually go through these different phases of clinical trials. Usually there is some work in a laboratory somewhere that has shown that some drug is promising in some way. Maybe it has helped in certain kinds of models that we have of cancer that we study in the lab, or in animal models of cancer. But for some reason, there's a drug that's been promising in some way. And so then the first step is what we call a phase 1 study. So a phase 1 study is where the sort of stated goal of a phase 1 study is really to determine more about the drug, side effects, dosing schedules, and how it affects people. Obviously, the reason, though, that we're studying these is because we think they're promising in some way. That's why we could even ask patients to help us do this kind of research. But a phase 1 study is a study of a drug that we're still learning about and trying to learn more about the dosing and the side effects. Once we have found a safe dose from these phase 1 studies, and it's been promising in some way and worthy of further study, we move into a phase 2 study. And that's more of a study to get a sense of how well does this work. And a phase 3 study is generally how well does this work compared to what we usually do. And so there was a phase 2 study of this drug given as a single agent or just on its own. And then there was also a phase 3 study of this drug that was recently presented at one of our international oncology meetings last summer. And what they showed was that when giving TAS-102 compared to giving a placebo, or really giving a pill that's not doing anything, that they found that TAS-102 seemed to improve how long people could live in terms of their overall survival. But the changes, but they came with side effects, and side effects included fatigue, diarrhea, nausea and vomiting, poor appetite, lowering of the blood count. So I think the TAS-102, but they did show improvements in survival, but the improvements were not remarkable, and so, or they were, I should qualify that. So the improvements, they mentioned that patients lived longer when they took TAS-102, but that amount of time was longer, on the order of 1 to 2 months, and on the order of 2 months, but it comes with risks, so it's always a matter of balancing risks and benefits. And I think that's a similar issue with the medicine Regorafenib that we just discussed. It has been shown to help patients live longer compared to not giving medications, but it comes with risks of side effects and issues, and the benefits in survival that have been seen both with Regorafenib and TAS-102 are not by large numbers. And so again, you're always trying to balance the possibility of living longer and living better with living better. And I think that's something we need to think carefully about as we're thinking about both Regorafenib and TAS-102, because many patients have seen benefits from drugs like this, but we're always trying to balance the benefits and the risks. So in summary, what I would say is that oral chemotherapy with drugs that have been FDA approved, like Capecitabine and Regorafenib, there are oral options for patients with stage 2, stage 3, and stage 4 colorectal cancer. The drugs that have been approved by the FDA that are oral agents for colorectal cancer are Capecitabine and Regorafenib. And oral chemotherapy is, like I mentioned, it's not right for everyone, but it can be a very good option for the right kind of patient. And again, that is really a decision that largely depends on patients and their priorities in their lives and what makes the most sense for them. And sort of going back to the table of sort of pros and cons, I think it makes the most sense for people who are tolerating pills without significant nausea, where their disease or their other treatments aren't making them so nauseous that a pill is hard to think about and hard to take. I think for people who are trying to limit their time in the clinic, for people who want some more ownership of what's happening and their treatments and the ability to do things at home and be spending more time at home or at work or wherever that may be and less time in the clinic, I think this is a very good choice. It's also just a matter of side effects, I think, for some people. And, you know, oral chemotherapy is still chemotherapy, and it comes with risks. And I think that's just an important point to understand with oral chemotherapy. There are certainly benefits and ease of being able to do things at home, but they're still important and serious medications and serious chemotherapy. I think that is all that I have, but I'm happy to answer any questions and work with Andy and Kevi to help to answer questions. Thank you very much.
Thank you so much, Dr. Varghese. We really appreciate the presentation, and we've had so many questions come in. So I'm going to transition now over to sharing some of our question slides. But in the meantime, I know that we're not going to be able to get to all of the questions, but we are definitely going to try to answer as many as we can. And so what we will do is ask as many questions as possible during this time, and then we'll perhaps do some more follow-up as well. So right now, a large number of the questions that have come in have been around taking oral chemotherapy at home and sort of the fears that may come with taking chemo at home. How are patients monitored on an outpatient basis with taking that chemotherapy?
It's a great question, and you know, every doctor does things a little bit differently. I can talk with you certainly about how I generally approach things and how I think many doctors do. You know, I think whenever we start any new medication, whether it's an IV chemotherapy or an oral chemotherapy or really many other medications, period, we want to see people relatively soon after you've started the medication to get an idea of how you're feeling. Sometimes I'll even ask either I'll call or I'll ask my nurse to give a call in the days following a new treatment just to see how someone's doing if I'm concerned about that. So generally what I would do for a medicine like Capecitabine, I would do one of a couple things. First, I would ask either I would call or I'd ask someone on my team to give a call in the sort of in the days after starting a new medicine, or I'll ask the patient themselves to give me a call with an update of how things have gone soon after they've started a medicine. A second thing that I'll usually do is make a follow-up appointment to see me in the clinic in a relatively short time, like like 1 or 2 weeks after starting a new medicine, to see how they're feeling or how they're doing. So let's say I'm starting that medicine, Capecitabine. That's usually given on a 3-week schedule, 2 weeks on and 1 week off. I might make plans to see someone after the first week or after the second week just to see how things have gone. If things are going smoothly, I don't want to waste people's time with an extra visit with me, and then I'll see them after 3 weeks, after they've had the 2 weeks of treatment and then the 1 week to recover from any side effects. So usually, as starting a new medication and starting a new oral chemotherapy, I'll try to just keep a closer eye on people over the phone if that's sufficient, or with a visit sooner than I might otherwise do in the clinic. And then if people are struggling with side effects or issues, let's say they've developed that kind of a rash, I'll need to see them right away to get a sense of what's happening, and maybe we need to stop the medication for, it can be days, it can be weeks sometimes, as those side effects get better. There's another conversation about whether or not to restart it at a lower dose, or whether or not to just stop the medicine altogether and maybe switch to a different option. So I think it's in terms of who can help you follow up with the side effects that come and the sort of concerns that come with starting a new medicine and a new oral chemotherapy in particular. Probably your medical oncologist who's prescribing it for you, and then and certainly reach out to, if you have concerns before they've scheduled that next appointment or before your next scheduled appointment, certainly call them and try and be seen sooner. You know, sometimes I'll see people in clinic and they'll mention so many side effects that they had, and I say, oh my goodness, why didn't you call me? We could have done something to help or done something else. And they think, oh, you know, I was on chemotherapy. I thought it was just going to feel like this. And you know, sometimes there are some side effects that we expect and that can come, but we can usually help people with some of these side effects and issues that they feel. So I would just encourage people to reach out to your doctor when you have concerns, and to your doctor, to their nurses, to the people who are working with them.
So related to that, do you think is it more challenging to find an effective dose of oral chemo versus IV chemo? And then also, are there more side effects? And then if there are severe side effects, can you go back to using your previous IV drugs?
Another great question. So, sorry, the first part of that question was, do you find that there are more side effects? Was that the first part of the question?
Yeah, so I think just finding an effective dose of oral chemo, is that
So that can be a struggle, and because, you know, the doses that are recommended, that can be a struggle for many people. And often the dose we start with is not the dose that we find, that's not always the right one. And so we often have to make changes, particularly in the beginning, and that's why it's so important to be in close touch with your doctor. So for Capecitabine and Regorafenib, both of them, if you start that medication, the recommended dose for many people is not tolerated, and so we often will move to a lower dose. And I know some doctors who will even just start at a slightly lower dose to begin with, because they know that it can be, they know that we can run into toxicities or side effects with the full dose that's usually prescribed. Sometimes people will even just start at the lower dose, and often will move rapidly downward if people are having side effects. And I would say that this is it's sort of a different situation for everybody, and I think everybody tolerates chemotherapy differently. And so it's hard to predict exactly how someone might feel or how someone might do. So it can be a challenge to find the right dose. And then you'll have other people where you start at one dose and they're fine and they're tolerating it well, and it seems to help their treatment. So it's really hard to predict, and that's part of what can make it a challenge to finding the right dose. Again, I think that really comes down to feeling comfortable communicating with your doctor and his or her team about the symptoms and side effects you have. And again, trusting your instincts. If you don't feel well, reach out for help. I think the other part of the question would be, are the pills harder to tolerate, or? Hello?
Yes, so related to that, can patients go back to using their old IV medications if they're experiencing significant side effects?
Correct. We do often switch from the pills to IVs if people are having difficulty tolerating the pills. So I've had patients where we've started on that combination of pills and IV. And then after the first treatment, after that first 3 weeks or the second 3 weeks, if we're having to, like if we try it at a 1 dose and then we try it at the lower dose and they're still having difficulty, we can switch from the pills to IVs. There are some studies to suggest that switching from the IV to the pills, that people have more side effects when you make the switch from IV first to pills afterwards. But that said, I have had patients that have had situations where we do that.
Okay. So with the recurrence, a lot of people have questions on the efficacy of oral chemo, and also is that effective in helping to reduce a recurrence of colorectal cancer?
Also a good question, and obviously that's I think getting to the heart of the most important questions that come for patients who have stage 1, 2, and stage 3 cancer, where the cancer may be in the colon or the rectal wall and may or may not have spread to the lymph nodes. And that's the point of those 6 months of chemotherapy, is to try to kill any cells that may be left there in an effort to help prevent those cells from having a chance to set up shop in a new place. And so, as I mentioned, the studies have shown that the combination of all IVs of 5-FU, leucovorin, and oxaliplatin in that scenario works as well as the combination of pills and IVs. The only, I think, caution that comes is that, as I mentioned, I find, and again, this is probably more anecdotal than anything seen in a study, is just that sometimes the combination of pills and IVs can be tough to handle, and so you may end up in situations where if you're holding a medicine, for a week while you're recovering from those issues of the hands and the feet, does that affect how well the treatment is working for you and affect your chances of recurrence? It's hard to know that one week or 2 weeks is making the difference between recurrence or not, or having recurrence. But I guess what you could say is that if you're always having to make changes and to hold your doses and things like that, that may impact your ability to be able to get the full treatment that your doctor has recommended for you. So I think, sort of officially or in studies, definitely we've shown that those 2 options are equivalent, and I think when they're given as they're supposed to be given, certainly they're both good options for people, and sometimes the pill and IV just makes better sense sort of for people's lives, and we know that they work as well as each other. But I think the concern just comes in situations where someone does have a lot of side effects, and again, it's hard to predict that. People end up feeling weaker and tired and having more issues, and then you may end up having to miss some treatments in a way that you wouldn't have if you did the all-IV version. But to be honest, some people have a lot of difficulty with the all-IV version too, and it's hard to predict one way or the other.
So do you think that as an option, once FOLFOX or FOLFIRI have quit working, is that something that capecitabine is then used, or what is sort of the treatment after that?
Got it. It's a good question also. So capecitabine is used sort of interchangeably with 5-FU. So if you've already had 5-FU, either on its own or in combination with oxaliplatin and irinotecan, and your cancer has grown or progressed on those medications, it's unlikely that taking capecitabine later would help, because you've already basically gotten that same kind of medication after you've already gotten that medication. Your cancer has already outsmarted it. So capecitabine is usually, I wouldn't recommend that as sort of another option after your cancer has grown on FOLFOX or FOLFIRI, because it's basically the same thing. So it's unlikely to provide further benefit. So capecitabine could be used, though, as part of that first treatment, or as part of the choice of, instead of FOLFOX, doing Capeox. Sometimes people are in situations where they stop the oxaliplatin and continue just with one medication, and so whether that's 5-FU or capecitabine, that would be a role where if the cancer is still responding. But if the cancer has grown on FOLFOX or FOLFIRI, I don't know that there's much further benefit to be gained from capecitabine on its own.
Okay.
That would be a situation where if your cancer has grown on FOLFOX or FOLFIRI, that you could think about either one of those other medications, depending on what kind of, whether or not your tumor has the right sort of genetic makeup for those other medicines, cetuximab or panitumumab. For some patients, that may be another option for you. Clinical trials, if you're in a place where you have access to clinical trials, could be another option for you. And then regorafenib would be another option for you at that point.
It sounds like there's, symptoms with the hand and foot syndrome with the oral medications. Do you know if anything can be done to address those?
Oh, sorry, yes, there certainly can be, and I definitely did not mention that, so thank you for asking that good question. So there are things that we can do to help with those symptoms. There are certainly creams and lotions and steroid creams, and to be honest, I'm sorry, I'm definitely not an expert in the dermatologic sort of treatment of the hand-foot syndrome, but there are several kinds of creams, and usually steroid creams and moisturizing creams that can help. And I can certainly, what I could do, Kepi, is I know we have a resource. I'll see if I can provide something for you that maybe you could put on the website. But there are things that can be done to help with those symptoms, most definitely.
Sure.
And then I think that goes along with many of the symptoms that come with chemotherapy, IV or oral, is that, and that's part of why I sort of stress calling for help if you need it, is because for most of these symptoms, there are things that we have that can help. I don't want to pretend that we make them go away completely or that people don't still suffer with side effects and issues, because I know they do. But we do have things that can help, and so that's why I encourage people to call their doctor and their nurses who help take care of them.
So there are a lot of questions, and I know that we may not be able to address them, but basically using this as a maintenance therapy, I know that you may not be able to address that, but where's a resource to direct patients that have a lot of questions about using like Xeloda, for example, as a long-term maintenance therapy?
And the question was just sort of how to do that, or?
Yeah, so there have just been several questions about using Xeloda as a maintenance agent.
And so that is a good question, and also one way that we use Capecitabine. So often when we're starting, let's say for patients with metastatic colorectal cancer, again, where our goal is to help people live longer and live better. If we, what we often do, we'll start with the combination, if people are feeling well enough, we may start with a combination of FOLFOX or FOLFIRI. Nobody quite knows which of those is better to start with, but let's just imagine FOLFOX with 5-FU, leucovorin, and oxaliplatin, or capecitabine and oxaliplatin, so FOLFOX or Capeox. Usually the oxaliplatin, although all of these treatments can come with side effects, oxaliplatin, one of its common side effects is neuropathy or nerve issues, so numbness or tingling in your hands and your feet. And so often what we will recommend doing, and what's been shown to be safe and effective, is after 3 months of that combination of FOLFOX, we will stop the oxaliplatin and continue the, and I say FOLFOX, and when I say that I mean FOLFOX and Capeox. So we may do that combination for 3 months and then stop the oxaliplatin, because we know that continuing the oxaliplatin increases a lot of the side effects and the neuropathy in particular. And then people continue, and they might call it or think of it as maintenance with either 5-FU or Xeloda. And we feel comfortable and safe doing that because the 5-FU or capecitabine is certainly the most important medication for the treatment of colorectal cancer. And we can continue that for as long as it's working, and it can be, and for many people it can provide sort of a maintenance of once a dose has been found that's effective and safe for that person, can sort of be kept on for as long as it's working for you. And if at some point the cancer looks like it is, and how long that is, nobody knows, whether that's weeks, months, or years, nobody knows that answer. But for as long as it's working for you, you can continue that as a single agent, 5-FU or capecitabine. And then if and when the cancer seems to be growing again, you could do one of two things. You could either add that oxaliplatin medicine back and start a combination treatment again, if your side effects from the oxaliplatin are not so bad, meaning if you don't have a lot of neuropathy left over from that treatment from before, so then you could add that medicine back. or you could consider adding a different medicine like irinotecan to that combination. So there is definitely a role for capecitabine as a single agent, or Xeloda as a single agent. And that's, again, I think another scenario where having a pill option that keeps you from being tied to the doctor's office every 2 weeks can be a good one, and can be a good one for maintaining your quality of life and your ability to travel and to do things and to be out if you're feeling well enough to do so. Great.
So is this oral chemo an option for patients that do have a KRAS mutation?
That's a good question, and unfortunately we don't have an oral option for patients with KRAS mutations. And actually we don't in colorectal cancer have a great option for sort of another great option for patients who have a KRAS mutation. For patients who don't have a KRAS mutation, that's where the cetuximab and panitumumab can play a role in treatment. But for patients who do have a KRAS mutation, we don't have another treatment, and there's not another pill that is sort of effective in particular targeting the KRAS mutation. And that's been an area certainly in colorectal cancer research that I think that we're struggling with and working on, because so many of our patients have KRAS mutations and we don't have a targeted therapy for that as of yet. There have been some promising studies in other cancers that have KRAS mutations, in lung cancer in particular, but there's not something FDA approved targeting KRAS mutations, and that has been a struggle in colorectal cancer and many cancers, because many cancers have KRAS mutations.
Okay, great. Well, this has been extremely helpful, and I know that we've had a lot of questions that we're not going to be able to get to today, so hopefully we'll be able to answer some of those in a follow-up posting, and we'll post some more information that Dr. Varghese can share on the hand-foot syndrome as well. I want to close with a final question just about what your thoughts are with the direction of oral chemotherapy. Do you think that there will be more oral chemotherapy medications that are going to be coming out, especially with the TAS-102? Is this the direction that we're going in, or will IV chemotherapy always exist?
That's a great question also. I mean, I think the backbone, I think there is a role for oral chemotherapy, and as you mentioned in the question, as we spoke about during the talk, TAS-102 has been promising in a similar space as Regorafenib, and I think that is, and I know given the promising phase 2 and phase 3 studies, I think there are thoughts that that drug could be approved at some point. When, who knows, if it would be approved, I certainly am not holding the key to that, and I don't know that answer, but I think there are thoughts that those studies have been promising to think that that could happen. So there are some oral agents on the horizon. I think with where we are right now, though, IV chemotherapy still sort of has an important role in the treatment of patients, and I think it will probably be a combination of the two. I don't know that we're moving to an all oral version, and I think in part that comes with this disease that can affect the GI tract and that can affect our ability to tolerate these medications and to absorb them appropriately. So I think part of this is with patients with colorectal cancer, period, there are some unique challenges that we face with being able to tolerate the oral medications. So although I do think there is promise in new oral medicines moving forward, I think there will always probably, or at least in the sort of near future, there will probably still always be a role for IV treatments as well.
Okay, great. Well, we want to thank you so much for this presentation. It has been so helpful, and I know that it's generated a lot of discussion, and we just really appreciate your time on presenting and answering all of these questions. I want to remind everyone that you can find us on the web and on Facebook. We'll be posting the slides. They're available now on our website, and you can also download a recording. So again, thank you, Dr. Varghese, for being with us today.
Sure. Thank you very much.